Hello, everyone, and welcome to the 19th edition of the UHN Foundation COVID-19 virtual Q&A. We hope you're staying safe and taking care of each other during this Omicron wave of the pandemic. I'm Christian Cote, host of the UHN podcast Behind the Breakthrough. We're so glad you could join us and grateful to you, our family of supporters who've been so generous throughout the pandemic. So a big thank you on behalf of the foundation and all of Team UHN. In today's episode, we're of course discussing the latest on the Omicron variant, including a new treatment for the coronavirus in Canada. Also, we'll be looking at keeping children safe now that they're back to in-class learning. And of course, we'll be taking your questions a little later in the program. To help us with your questions, joining us today, we're so pleased to be joined by Dr. Alon Vaisman, UHN infection control physician. Welcome, Dr. Vaisman.
Thank you. Thank you again for having me.
Let's start off big picture with the number of Ontarians who are hospitalized or in ICU because they're infected with the coronavirus. It's higher than any previous wave during the pandemic, yet we keep hearing this narrative out in the mainstream media, it seems, that the virus is less severe or it's mild. Can you help shed some light on what all this means?
Yeah, I think it's a very important point. And one way you could think about this problem is to think about it on two levels, the individual level and the overall societal level. So on the individual level, if you are fully vaccinated, double or triply vaccinated, if you acquire Omicron, your chances of having severe outcomes related to Omicron is less compared to the most recent variant prior to Omicron, which was Delta. So for you as an individual, Omicron is less severe than Delta. However, on a societal level, Omicron has resulted in significantly more cases because it is more infectious, and we think it also is its ability to infect people who previously had COVID before, say with Delta. So on a societal level, even though it may be milder for individuals, it's resulted in a high number of hospitalizations and a high number of cases because it spread so quickly. So even let's say if the severity, just estimating, let's say it's half, if you infect double the number of people or triple or four times the number of people, you've more than offset that effect of being less mild. So certainly there is more infectiousness, and that's why we're seeing this effect.
So would it be best to just sort of pitch those descriptors in terms of severe and mild? It's not really, it's a bit of a misnomer right now.
Well, for an individual, it's going to be more likely to be mild. If you are not vaccinated, you are still likely to experience, or you're still able to experience the significant side effects associated with COVID, including hospitalization and death. But if you are fully vaccinated, you are less likely compared to Delta. However, if you end up infecting a large number of people, you will end up resulting in still a significant number of people who get severe illness. So it's not impossible for people to get severe illness, but given that it's infected so many people, that's why we're seeing so many people who end up being hospitalized and are dying, unfortunately.
Okay, so for those adults who remain unvaccinated in Ontario and become infected with the coronavirus, is their percentage risk of being hospitalized, admitted to ICU, potentially death, is that higher than those who are vaccinated?
Yes. So for those people who are not vaccinated, they are still at higher risk of experiencing severe complications compared to an individual who is vaccinated. And around the world, the estimates differ, but here in Ontario, it's somewhere between 15 and 20 times. So if you compare one individual who is vaccinated and one who is unvaccinated, the person who is unvaccinated is about 15 to 20 times higher likely of being hospitalized and then subsequently potentially dying from COVID. So yes, certainly Omicron still has potential to do that, and we're still seeing that here in Ontario.
Okay. I've also read recently where if you're vaccinated, the risk of long COVID is reduced. What can you tell us about that?
That's a very important point, because when we think about what are the side effects of COVID outside of people being hospitalized, is the recovery period. Some people who recover from COVID experience long-lasting symptoms. It's hard to know what the estimate is. It ranges in different studies, from say 1%, around 5%, 10% in some studies. But interestingly, new data that just came out this week in a preprint showed that if those individuals who are fully vaccinated get COVID, their likelihood of developing long-term symptoms is extremely low. In fact, it is similar to those who didn't acquire COVID at all. So essentially, vaccination has a high level of protection against long COVID. And interestingly, a similar study was done in children looking at the protective effect of vaccination. And this disease, a multi-inflammatory system disease that children get as a result of COVID, also is reduced if you get vaccinated. So what this tells us is that vaccination really is doing its job. It's protecting us against severe side effects and long-term side effects.
I also want to talk about infectious period and isolation if you get the virus. This week, the British Medical Journal published data indicating the amount of viral RNA in the body is highest 3 to 6 days after diagnosis or symptom onset. What's the latest in terms of then the recommended isolation period for people in Ontario before you become socially active again or go back to work, say?
If you are infected with COVID, the time that you're supposed to be isolated, it has changed recently as per Ontario guidelines to 5 days. But in many high-risk cases, for example, here in the hospital, we would still isolate you for 10 days. So the reason 5 days was chosen, despite the evidence that you're describing, and which is what we knew to some degree was true for previous variants, is a balance that the government and other jurisdictions like the CDC in America tried to strike, where we're seeing a high number of cases affecting a lot of essential workers. So it's a balance between trying to get people back work early and not continuing to expose people to COVID. So it's, people argue that this is not safe or it's not scientifically based to reduce the isolation period from 10 to 5, which was done here in Ontario and other places. But what they're trying to do is trying to at least maintain societal function, essentially, where police, power plant, healthcare workers, everyone can actually come back to work. Because if we had a large number of people off at the same time, which is what Omicron is doing, then we might have a significant shortages in those sectors. So while it's true that 10 days is likely the safest, 5 days was trying to strike a balance.
So if you potentially have that leeway, you might be better off actually isolating for 10 days.
Yes, and it is and in the Ontario guidelines, it is recommended for those individuals in more high-risk settings, for example, hospital workers, that you should maintain the 10-day isolation, which is what hospitals continue to do in Ontario.
So if someone gets the Omicron virus and recovers, what do we know about their immunity level and protection against reinfection?
That's the $1 million question, because one of the most serious and most risky features of Omicron is its potential to cause what we call immune evasion, which means that we suspect that a lot of people who had Delta or other variants before acquired Omicron because it can evade immune system. But we don't know is what happens if you acquire Omicron. Can you pick up Omicron again? We suspect that the answer is going to be yes, but if it's going to be a much higher degree than previous variants, then we're going to unfortunately see repeated waves of COVID again and again. Whether that translates to severe disease is unseen and unknown, but we suspect that Omicron, you will likely be able to reinfect, but it's still a bit too early. If you think about when Omicron was discovered, it's only about 2.5 months ago, or even less. So we don't actually know to what degree the reinfection is, but we suspect it's going to be much higher than before.
Okay, this week, another bit of welcome news in terms of the fight and treatment of the coronavirus. Health Canada approved Pfizer's Paxalvid antiviral medication. It's a drug in pill form to fight the virus. It reduces symptoms from the infection and shortens the period of illness. What do we know about the efficacy of this drug?
So unfortunately, the data that's related to this drug has not been released in a peer-reviewed publication. And although it has been approved for use in other jurisdictions, including the United States and here in Canada, we don't actually have the full data. All we have is releases from the company essentially telling us what it shows us is for people who are susceptible, in other words, not vaccinated, it is highly effective at preventing severe illness. They quoted around 89%. And then for those individuals who are vaccinated, there is still some prevention and hospitalization, not as good. So if you translate into what we call numbers needed to treat, you would need to treat 17 unvaccinated people with this drug to prevent 1 hospitalization, which in medical terms is actually quite good. It's a very high efficacy. The limitations with Paxalvid, unfortunately, is that we don't have a good supply here in Canada. And secondly, the drug can have interactions with other medications. So what we foresee is Paxalvid used in a subset of people who have either not responded to the vaccine or have not been vaccinated in order to try to prevent hospitalization. But still, the best line of protection is to get vaccinated.
I'm just curious, Alon, if I could explore the Paxlovid with one more question in terms of the potential impact once supply becomes a non-issue. What's your sense of its impact on the hospital system in terms of care and hospitalization?
Yeah, it's a great question. Again, because we don't have a lot of data on it, we don't know exactly how it's going to work and how well it's going to work. But yes, if it is widely available, then we should see reduced hospitalizations, particularly among the unvaccinated, which, as we discussed earlier, still make a significant proportion of admissions to hospital Ontario. The other side of it is that if you use it in people who are more susceptible, like elderly people, immunocompromised, the challenge there is that this drug happens to have a lot of interactions with other medication, which means that the drug may not be efficacious, or which would mean that it would changes the efficacy of the other drugs you're on. So there are limitations to using this drug, but certainly if it's used in a safe fashion, we could see significant reductions, hospitalizations, if it's widely available.
All right. This week, Ontario students K-12 are back to in-class learning. That's the first they've been in class really since the Omicron wave started. What does the modeling tell us, or do you know, in terms of how this return, what might play out over the next, say, 2 to 4 weeks?
It's a great question. Unfortunately, where we look commonly for the modeling, the science table hasn't released yet their numbers regarding what they anticipate to happen. But I think most people who are closely following the situation would say that we're likely to experience a bump. So if you just look at the overall situation here in Ontario in January, most evidence now points, especially in Toronto, that we've already peaked, probably sometime last week, Thursday, Friday, Saturday, and that numbers are falling. Particularly here at UHN, all the numbers indicate that the numbers are falling down, which means that we're on the decline. But with schools opening, we're likely going to experience some bump again. It seems unlikely it's going to be as bad as it was earlier in January, but we're likely to experience a second peak some point as a result of school. And hopefully it won't be as bad, and hopefully we can overcome it quite quickly. But we just don't know to what degree that's going to affect things.
Okay, and not to alarm people, but kids are getting COVID, kids are being hospitalized. What would you say to parents in terms of they're going back to school now? How do you protect them?
I think every parent needs to think very carefully for their own student, whether they feel comfortable to sending their kid back to school. Personally, I believe it is likely safe in most scenarios for kids to return. One, because ages 5 to 11 are offered vaccination. And as I said, vaccination offers high level protection against severe outcomes, including the inflammatory disease, which kids are susceptible to. The second thing is that bad outcomes are associated with age, and that's a very clear association. The younger you are, the less likely you experience severe outcomes, death or hospitalization. So the elderly population is the most at risk, and this is what we've known since the beginning, which means that even if a child acquires COVID, the likelihood of them having severe outcome is still remarkably rare. And so that's an important thing to keep in mind. The third is that there's a lot more protection that's been introduced to schools compared to, let's say, December, November. So we have masking, we have the improved ventilations, HEPA filters have been introduced, and rapid tests were introduced again during the winter break. So there are increased measures available to people. So on the whole, I would say there is a lot of safety measures. But of course, some parents may feel that that's still not enough. Hopefully, a lot of people do feel comfortable this safe to go at this point.
You mentioned rapid testing. I'm wondering, would you suggest, say, parents implement some kind of testing regimen for their kids in the morning and in the afternoon, before or when they're coming home from school?
Yeah, the tricky thing about rapid testing right now is the availability of tests. And I think parents should follow the algorithms that are provided to them by the school board or by the public health district that they're living in Ontario. So after the break, a lot of students, or during the break, actually, students were provided test kits. And then usually they came with instructions from the school about how to use them and how frequently to use them. The challenge now is how to use them more rationally if you don't have so many left. The other unfortunate piece of the puzzle is that the rapid tests are unfortunately not as sensitive at picking up COVID in Omicron as they were to previous variants. So there is some limitation. So I think parents should recognize that there is not as there is limitations to getting a negative test, for example, when you swab with the rapids. So they just need to follow the instructions from their local boards in order to understand how to use them.
And in terms of masking, I read recently the CDC in the US has recommended higher grade masking. What's the latest here in Ontario with regard to masking protection?
So this also follows consistently with what Dr. Theresa Tam mentioned back in November when she released a statement that Canadians should be upgrading their masks to masks that are well-fitting. This includes a variety of types of masks, including N95, KN95, and well-fitting medical masks, surgical masks, for example, that we provide here at UHN for our staff and for patients. So any one of those three would be acceptable. Some people do have access to K95s or N95, certainly acceptable to use them, but it's not entirely necessary. I think for most settings, especially in public settings, a medical mask is sufficient. If you can use a K95, you can certainly go ahead. With N95s, I think people need to recognize that although fit testing is required for N95s, you'll likely get away with certain models that are able to fit most people's faces. So although it's not ideal, you may be able to fit nicely into N95. And just to recognize that N95s, because they fit so tightly, people who are not used to wearing them are going to feel the need to adjust them or remove them. And really the highest risk of transmitting COVID is when you're not wearing your N95. So if you're not familiar with using one, you're not comfortable using one, just use a mask that is well fitted, that you're not going to remove, because we don't want you to take them off and be exposed. So I think that's an important message for people who are thinking about changing their masks.
The measure of virus spread seems to have transitioned over the last, week or two, in terms of we have gone from the daily case count to the measure now seems to be hospitalizations and ICU admissions. Is there a risk at all in terms of losing that larger measure of the case counts, the daily case counts in Ontario, in terms of, effective public health strategy?
Yeah, it's really an important shift that has occurred in Ontario that is really going to shift our entire approach to COVID, which really is preparing us for the future of how COVID is going to be managed in the future. If you think back to why restrictions were introduced in the first place back in 2020, the name of the game was always protect the hospitals from overwhelming number of cases, because patients coming in with COVID or those who don't come in with COVID will suffer if the hospitals are overwhelmed. So watching that number is really the critical piece still, even now. The overall case numbers were just giving us a kind of a surrogate marker of that problem as well. And I think it's important for everyone to shift their thinking now that for other respiratory viruses, we never actually test outpatients for the most part. We only tested inpatients. And that's what COVID is now shifting to, is that if you have any kind of upper respiratory infection and you're not sick enough to come to hospital, the general recommendation is just don't leave your house. I mean, that's really what it was before. People didn't really follow that, but now that's really more important than it's ever been. So people need to kind of shift their thinking that COVID you don't actually need to confirm your COVID status in most settings for most people as an outpatient. And it's really more important for certain high-risk settings, certain healthcare workers, and of course, hospitalized patients where we actually are able to test them. Schools is kind of a gray zone where we want to understand the transmission, but availability of testing is now limited, so we don't really have that information. But I think everyone needs to start thinking about COVID very differently as we exit this wave.
Well, and to that very point, I've also been reading how, in terms of that shift, some of the debate is around we should shift the focus from managing the coronavirus to containing it. Explain that to us.
Well, I think the mindset of people over the last 2 years about coronavirus either hasn't been very clear about the goal, or some people have had the goal of actually eliminating altogether. But with the onset of Omicron and with just simply the length of this pandemic, people are kind of getting around to the idea that this virus appears to be going to be into the usual winter milieu of respiratory viruses, which means that we want to make sure that it's not causing severe disease in most people, i.e. vaccinating them, and we want to make sure it's not overwhelming the hospitals. So anything we do in the future to control COVID should be aimed at that measure. That's really what we're trying to do, protect the hospitals, protect the medical system from being overwhelmed. So we're, again, identifying lots of thousands of cases. If that's not going to help in that measure, in that regard, then it's not necessary. Trying to do things that eliminate the virus are not going to be helpful. So it's really focusing now into just containing the virus to not cause these very severe outcomes in people and not overwhelming the system. So that's the shift that we're moving towards right now.
So really, this virus, as it continues to evolve, is likely to be with us for a long time, perhaps if not years, decades. I keep hearing about though that the Omicron variant may now even be mutating to something called BA2. Are these mutations, though, is your sense that the way this has behaved up until now, are these mutations diminishing in their potential to spread and cause or warrant still being known as a pandemic?
That's again the $1 million question of where we're headed. Because if you look at other coronaviruses, so there are coronaviruses that cause common colds, it's theorized that these were likely more severe, kind of like how COVID was, and then they mutated to become less severe, quite transmissible, but not causing severe disease in the vast majority of people. That's the $1 million question. Is that where COVID is headed? So far with Omicron, it's reassuring that, as we discussed earlier, it's less severe compared to Delta. So although it's more transmissible, it's not causing as many deaths compared to the previous variant, which is Delta. So there is some evidence, suggesting exactly what you described, that we're actually, as these things are mutating, they're becoming perhaps more transmissible, but less severe. That would be really the best piece of good news we can get with this pandemic. And yes, it's going to come around, it's going to continue to infect people. But as long as the vaccine continues to do what it's supposed to do, which is to prevent death and hospitalization, which it is, then overall we'll be okay. And that's really the bottom line is, can we prevent death and hospitalization? And if we can continue to do that, then it doesn't matter as much about the virus, what it's doing.
But would the caveat not be, though, that you mentioned that, yes, it seems to be indicators are that it is becoming, let's say, less severe, less mild. But as we talked about at the outset, that's if you are triple or double vaccinated at the very least.
Yes, exactly. That is with the caveat that you need to have been vaccinated in order to protect you from those severe outcomes. Even if you have had COVID in the past, you still need to be vaccinated to protect you from those outcomes. It's not as clear to what extent just simply being infected protects you against those severe outcomes, but it's not advisable that you would get COVID in order to gain immunity in that way. But just going back to your earlier question, I mean, we could be wrong, and obviously the virus can mutate in such a way that becomes more deadly and more difficult to manage. So far, the evidence hasn't shown that, but of course, everyone needs to understand that that's also a possibility. As you mentioned, there's a new variant that's out there. As we learn more about it, we may learn that it is more transmissible or more deadly, but it remains to be seen.
All right. As we mentioned earlier, also, the rate of hospitalization for COVID infection is at an all-time high, the highest it's ever been since March of 2020. Healthcare workers are burnt out. Some are leaving the profession. Your group in particular has been extremely busy the last couple of weeks with outbreaks. Talk to us about how you and your colleagues are coping at UHN.
That's a very good question. I think all I can say is that people have gone above and beyond to do whatever they can to help the system. There's no doubt that there's burnout amongst all various staff, whether that's physicians, nurses, our infection control practitioners, or physiotherapists, social work, every profession you could think of likely is experiencing some degree of burnout right now. So the question of coping is it's a very hard question to ask, is what are the best methods of coping with the scenarios and how do we best prevent people from burning out in these cases? Of course, the number one reason people burn out is workload. So the message to the audience would be simply that whatever you can do as an individual to try to prevent the workload from increasing, that is to say, preventing COVID transmission, helps us here in the hospital, helps the nurses, helps all the frontline staff seeing patients, helps everything get back to normal, essentially. So really, that's all we could do in terms. I think that's the single most important thing to help us cope, is to try to just reduce COVID and get rid of it. Again, vaccinating is also part of that question.
Exactly. All right, let's turn to the audience questions that have been coming in throughout our little chat here. Let's throw them up there, Amelia, if you can. All right, Alon, here we go. What is the recommended approach for how and when to use rapid antigen tests? There's been much media lately about questionable effectiveness, timing, throat versus nose swabbing.
So there's two ways you can consider using a rapid test, and generally it's used in the first way, which is for asymptomatic scenarios. So if you don't have symptoms, and let's say you're doing some kind of high-risk activity, like you're going to a school, you're going to a congregate setting, for example, for a healthcare worker, or you have a large meeting, for example, with large people, a rapid test could be helpful in detecting COVID in that case. Unfortunately, it's not as sensitive as we'd like it to be, so there's a good chance that even if you have COVID, it's not going to be able to pick it up. For symptomatic people, you can use rapid tests, although that's not generally the recommendation. You could do subsequent rapid tests within, let's say, 12 hours of one another or more to try to pick it up if you test negative the first time and you remain symptomatic. But generally speaking, the indication would be for asymptomatic cases. As for throat versus nose swabbing, currently the manufacturer of the most common rapid tests that we use, like the PanBio by Abbott, hasn't changed to recommend using the throat as well. The recommendation is currently just the anterior nares or the nose swabbing. So it's important for people to follow the instructions. There have been anecdotes that people say that using a throat swab actually increases potentially the sensitivity, but it's hard to know. And I would just say that just use it as recommended for now. And in terms of the timing, basically, again, it depends on your specific scenario.
Well, sorry, I was just going to add also that they aren't necessarily designed for throat swabbing.
That's right. People have been doing it on their own to try to get try to pick up the virus in their throat, but you're right, it hasn't been specifically designed for that.
From Bet Smith in Markham, how many days before and after symptoms are people infectious?
So with Omicron, there doesn't appear to be a significant change in terms of the distribution of days. So it's still 2 days before the onset of symptoms, and then to approximate maximum of 10 days after the onset of symptoms. If you have no symptoms whatsoever and you test positive for COVID, we just measure approximately 10 days after, and again, 2 days before. If you develop symptoms, again, you use the same kind of algorithm. As you mentioned earlier, Christian, regarding the peak of virus, some studies have shown that the peak may be a little bit later with Omicron compared to other variants. So before, we thought that with other variants, your peak viral load is about the day or the day before you develop symptoms and then drops off. With Omicron, it may be a little bit later. But in any event, that 10-day mark is still what we suspect is the case for Omicron overall.
Next question. How much less likely is a vaccinated person to transmit the virus than an unvaccinated person?
That is still in flux, to answer that question. So we know that if you are fully vaccinated with previous variants, your likelihood of picking up the disease with mild or asymptomatic, it was reduced by 90 or 95% compared to unvaccinated people. With Omicron, unfortunately, that number has dropped significantly. Same with, to some degree, with Delta as well. So with Omicron, we don't know where that number is exactly, but it could be somewhere between 40 and 70% of chance of picking it up. So in other words, it's not doing as good a job at protecting you from picking it up, the virus, still doing an excellent job against preventing death and hospitalization, absolutely. But simply picking it up, it's not as good. Certainly it does protect you to some degree. The question of transmitting onwards is another complicated question. It's a little bit hard to answer for Omicron, how much less likely you are to pick it up, but we know that to some degree, you for sure are less likely to transmit it if you've been vaccinated compared to unvaccinated. Part of that is because your viral load is going to be overall lower if you've been vaccinated. So to answer the question, I would suspect it's somewhere in that same range of 50 to 70% chance of transmitting it if you have been vaccinated compared to if you haven't.
From Gail, how do I treat a case of Omicron at home, presuming it is mild enough that I don't need to go to hospital? What supplies do I need to have on hand?
So that is, generally speaking, most individuals who pick up COVID and do not have any kind of comorbidity, so other illnesses, and are not elderly, there isn't anything specific you need to do aside from doing supportive measures. So let's say you're a young and healthy individual. If you pick up COVID and you're at home and you're isolating, things like Tylenol or ibuprofen will be helpful, staying hydrated, watching out for symptoms that may indicate severity like chest pain, shortness of breath, dizziness, vomiting, things like that. You'd go to the hospital if you have those. But I do want to alert people that in certain cases where people have high-risk features, they may be indicated to receive what's called monoclonal antibodies. Unfortunately, the supply is not very good right now in Toronto and Ontario in general, but there are ways you can get it. So if you do have one of these comorbidities, which in general is people who are elderly and have other diseases like heart or lung disease, for example, if you fall into that group, you should contact your doctor who can help facilitate trying to get you that therapy. And there is a window in which you should get it. So it's important that you do that within the few days after you get diagnosed.
That's right. Yeah. From D. Cuvier, why are so many vaccinated people getting hospitalized with COVID? Frequently, there are more vaccinated people in ICU than there are unvaccinated. I am triple vaxxed and wear KN95 and face shield when I occasionally go out. What more can we do? So almost two questions there for you.
So the reason that we're seeing so many vaccinated people in the ICU compared to unvaccinated, it's now more than 50%, is simply because almost 80% of Ontario of any age is fully vaccinated. So just simply because there's more of them. So as a total proportion of ICU patients, the vaccinated make up more than half. But as a proportion of vaccinated patients in general, the ICU numbers are tiny. Whereas if you compare that to the unvaccinated, the ICU numbers are much bigger. So if you are unvaccinated in Ontario right now, your risk of being hospitalized, again, is probably 20 times higher than compared to somebody who's vaccinated. So, but just simply because millions of people are vaccinated, they're bound to get in the hospital. Which people are those? Those tend to be people who are elderly or immune compromised who have not responded well to the vaccine. That's generally what we're seeing in the hospitals of the vaccinated group. And yes, regarding the ways you can protect yourself, wearing a tight-fitting mask, such as a K95, is certainly all you need to do when you go outside. I mean, the same things that we've talked about are what you need to do to maintain distance, to wash your hands, wear a tight-fitting mask, don't go out if you're sick, don't stand close to other people who may be sick, don't meet up with sick people. Those are all the same kind of recommendations that applied since the beginning of the pandemic. So to answer your question, there isn't much you need to do more than that.
Next question, can you provide updated guidance in light of Omicron for the safety measures we've learned over the last 2 years? Example, Is transmission on surfaces still minimal? How effective are masks, double masks? Should we be getting N95 masks? Does 20 seconds of hand washing still kill it? Does laundry kill it? So a lot of questions there. First of all, surfaces and masks.
So in general, the transmission through fomites or inanimate objects is still unlikely to occur. That's not to say that it can't happen, and still we should be washing our hands, but it's fairly easy to kill COVID in general. And part of the reason we don't see transmission that often from this method is simply because people have been doing a good job cleaning surfaces and washing their hands. In terms of laundry, I mean, you don't really need to do anything with laundry, anything different than anything that you would otherwise do, because again, it's very easy to kill. Even 20 to 30 seconds of an alcohol rub would kill COVID. So COVID is very easy to kill on surfaces. So still important to maintain those things, but it's not a common mode of transmission. In terms of masking, still the recommendation, as we talked about earlier, as Teresa Tam mentioned, as Dr. Moore mentioned, is to use a mask that is well fitted to your face. So in general, cloth masks are not going to be good enough. So again, N95, KN95, and well-fitting medical masks are the masks that are going to be good and tight-fitting. If you have a 3-layered cloth mask, that may be okay as well, but again, you have to make sure that the fit is very good. So to answer the question, that those are still the recommendations that we would put out for people in general.
And we should also mention, you were talking about fomites are a reduced risk factor. Airborne or aerosolized COVID really is the main issue.
Yeah, I mean, if we can talk about the transmission, that's an excellent point. So when you think about how is COVID transmitted, maybe if we go back to kind of basic principles, there's 3 ways COVID will be transmitted. One is through surfaces that we talked about. Another is through droplets. So when somebody generates large droplets when they're sneezing and coughing. And the third is through what we call opportunistic airborne transmission. And when we see that, generally speaking, in very tight areas where ventilation is very poor, and that generally results in long range transmission, which I would say isn't the most common. It's most common for people to transmit it in very short ranges, actually. Almost every single study looking at COVID transmission shows that the vast majority of transmission occurs within 1 meter of an individual who's infected. Hence why distancing is so important. That's not to say at 6 meters you can't get infected. It's just far, far, far less likely to have occurred. So really that distancing and close contact is really the most important to try to prevent COVID.
From Eileen Little, I've heard on the news that we are expected to peak at end of February, and then this virus will disappear. So my question is, do you believe?
So it looks like we've already peaked to some degree in Ontario, and it's likely going to come down, and maybe again, as we mentioned, might peak again due to schools. But when we say disappear, or when you mention disappear, it's not likely to disappear altogether. So why is it that COVID isn't going to go away ever? There's a few reasons. One is that it's transmitted to the entire earth at this point, and hence, if anyone is unvaccinated around the world, or even for some vaccinated people, it's still going to be transmitted back and forth between them. So it's going to be hard to get rid of that. The second thing is that there are animal reservoirs. So animals can acquire COVID, whether that's animals in like the cat species, the mouse species, other kinds of mammals, birds, lots of animals can get COVID. So which means that as long as humans are living in close contact with animals, it'll be transferred back and forth between us. So because so many people are exposed and because there's animal reservoirs, we really can't eliminate this disease. And like other coronaviruses, what we're likely to see is some kind of, periodic wave associated with COVID. And hopefully it won't be associated with the same level of hospitalization and death. So if we have a highly vaccinated, highly endemic virus where a lot of people have been immunized or immune due to exposure, we're less and less likely going to see deaths associated with that. And that is essentially the story of influenza. As you may remember, H1N1 was a virus strain of flu that showed up in 2009 that hadn't shown up for a long time. That caused a significant pandemic in 2009. But ever since 2009, H1N1 has been one of the predominant strains every single flu season. And yet you don't hear the word pandemic being used for flu. And that's because vaccination and exposure due to the virus. And so there is now more immunity to that virus. And that's what we hope will happen with COVID.
From Tess, what type of surgeries are currently occurring at UHN, and how are surgeries prioritized during this time of HHR shortages due to COVID? What kind of strategies are adopted to keep surgeries close to normal levels? Thank you. Well, I don't think they're normal. They've been reduced by 50%, correct?
Yes, I'm not exactly sure the number, but there, as you said, there is a significant drop in the surgical procedures being done at UHN. And part of that is due to having staff redeployed to do other work in the hospital related to COVID, to look after patients who are admitted, plus to provide some space in some instances for COVID patients to be admitted. So how is the strategy being adopted? Basically, the hospital is very closely looking at the numbers, very closely looking at the available human resources. And as soon as possible, we want to open up the surgery to the surgical units and the surgical ORs to allow patients to try to get in, to prevent the backlog from getting worse. I don't know about the specifics about exactly how much is occurring, but basically there is a strategy that UHN has developed to try to cut back to only the degree that we need to allow for patients who are coming into the hospital acutely. And really, we will never want to actually stop doing emergent surgeries. But if you think about a scale of emergent surgery all the way to surgeries that have a certain degree of waiting, we're somewhere in the middle of that right now, obviously. So it's just a matter of trying to closely titrate that from week to week.
And we should clarify, that's not UHN does not designate or set those rules. Those are rules that come from Ministry of Health.
That's a very good point. All the hospitals in Ontario follow a certain pathway in order to reduce surgeries or uplift or increase the number of surgeries based on that directive.
We just have to have the plans ready to go, whether we're scaling up or pulling
exactly.
back.
But I mean, needless to say, if you need surgery or emergently in UHN, you will obviously be provided the surgery. If you need to come to hospital if you're acutely ill, you should absolutely come to hospital if you're acutely ill.
Good point. From Susan, I am a 73-year-old senior. I do my own shopping, but have started using online shopping more often. I live alone and walk my dog every day, keeping distance. I have one friend at a time visit me. We keep masks. Am I being overly paranoid? I'm very anxious and lonely. Please comment. Thank you. Oh, I'm so glad you wrote us, Susan.
Yeah, I think every individual is going to have their own idea of what's risky and what's not. I think if you're an individual who's severely immune compromised, your sense of what I should be doing is going to be very different from somebody who's not. If you're 73 years old, you're obviously on the higher end of risk associated with COVID. Being fully vaccinated reduces that risk substantially. So it means that you certainly can participate in things, day to day as being described. I think that's very reasonable. I wouldn't call these individuals paranoid in any way, because I think people are being careful and trying to understand the risk. I think the degree of what you're going to be doing outside really depends on what's going on outside. If COVID cases are insanely high, like they are right now, it makes sense to pull back on some of those things. But when COVID cases come down, which we hope they will in February and March, doing things in the grocery store or going out to a restaurant would certainly be reasonable at that point for most individuals, I'd say. So I think people need to be very careful to watch the numbers and understand the risks as we move forward with this. It would be a shame for people to continue to be not going out, not doing anything when the risk associated with COVID ends up being very small because we have very few cases. So people need to watch that. And right now is obviously not that time.
Exactly. Next question. The disproportionate use of hospital resources, staff, operating rooms, ICU, etc., has led to delayed diagnosis, treatment, surgery, resulting in needless additional suffering and death. Has consideration been given to proportion hospital resources to the non-vaccinate based their percentage of total population?
So this is obviously a hot issue that's circulated around the world in Europe, United States, Canada, about how do you deal with patients who are not vaccinated? Is there any punitive measures or tax that you should impose on them? Quebec, people probably heard about some kind of financial, measure being imposed on them. I think most physicians and most people who provide care to patients would agree that we shouldn't pass judgment on patients, whether they're vaccinated or unvaccinated, and provide the care that we need to. And that we shouldn't triage patients based on their status of being vaccinated or unvaccinated. There's no doubt that patients who are unvaccinated get sicker and come into the hospital with COVID. There's no doubt that that's frustrating. But personally, I wouldn't translate that into any kind of reduction in treatment for those individuals or restriction in treatment for those individuals or providing some kind of financial punishment to those people. Personally, I don't think that's indicated. I don't think it's ethical. I think we also need to understand that these anti-vaxxer people, they are not the majority of people who are not vaccinated at this point. There's still a significant number of people who feel hesitant for a whole variety of reasons. It's not what we've kind of characterized or caricatured as like a paranoid, conspiracy theorist. There's still a lot of people who do not fit that and remain unvaccinated. So we need to have some degree of sympathy for those individuals as well. Of course, we want them to be vaccinated. Of course, it's unfortunate they're not, but these kinds of measures, I'm not sure how beneficial they are or what they're really going to accomplish.
It's well articulated. Thanks, Alon. From Merrim, I had cold symptoms a couple of weeks ago, lots of cough, mild headache, and a funny sensation in the throat. Did not do a rapid test to check for COVID. How can I know whether I had COVID or not?
So at this point, for individuals who do not meet the criteria, you really can't check now if you had COVID. If it was 2 or 3 weeks ago, you may not even have a test available to actually do it. So the PCR test that we did traditionally, or we still do, the nasopharyngeal swab, that can detect COVID weeks after you've had it. Some people will have a positive COVID test for 2 weeks, 3 weeks. Some people have for 6 weeks or even 6 months. But at this point, you may not be able to detect it even if you could do an NP swab. Again, if you don't meet criteria to test, you really can't test it at this point. And a rapid test will not be helpful at this point because it's only positive in the early onset of the illness, typically within the first 4, 5, 6 days or so. So at this point, there's no real way you could do it. You could measure antibodies, but antibodies are tricky to measure, and they're only done really in research settings, and it'll be hard to interpret if you've been vaccinated in the past. So there's no real easy way of doing that right now for you.
Yeah. Is the Delta variant still active in the community? Am I at risk from both the Delta and the Omicron variants?
Right. So there is still a handful of cases associated with Delta. In most jurisdictions, it's 1% or less of cases are still Delta. So the big question, though, is how much reinfection can you get between Omicron and Delta? If you've had Delta recently, can you get Omicron right away after that? It seems that that's unlikely to occur, but the question is whether you can get it faster than, let's say, if it was 2 exposures to Delta. So, faster than the 90 days that we use. And the theory is that probably you can get it faster with Omicron if you've recently had Delta. You can't get 2 strains simultaneously, though. That seems to be very unlikely or extremely rare to have ever happened. And really the question going forward won't be so much about Delta, but it'll be about Omicron reinfecting you again. And as we discussed, that's still uncertain at this point.
Mm-hmm. What's the most positive thing you can tell us about the pandemic right now?
The most positive thing I could tell you is that vaccines work. They work.
Yes.
And really, so when you think about the worst outcomes from COVID, death and hospitalizations, vaccines are doing an excellent job protecting us. The second bad outcome from COVID is long COVID. Vaccines protect us against that too, as well. So that's really the most important thing, is that if you get vaccinated, you can avoid all the awfulness from COVID. You won't avoid potentially picking up the disease or transmitting it. But then again, the same thing applies to cold and flu. The flu vaccine perhaps is not as efficacious as the COVID vaccine. So that is the most positive thing. The second positive thing, if I could slip in one more, is that it's likely looks like we've peaked here in Ontario. There's still a lot of data, still preliminary, but it looks like we're coming down now.
Great news. From Christine, I think this is a question we just dealt with, but we can tackle it if you think that there's anything further to add, Alon. Years ago, TB treatment centers were common. Segregated patients were treated. The unsustainable model of prioritized unvaccinated COVID patients who preempt surgeries diagnosis is inequitable. Conditions deteriorate. Why isn't a COVID treatment center established to allow equitable healthcare?
So there's 2 important concepts here. The reason that patients with TB were separated 100 years ago was to prevent other people from picking up TB from them. And, we're not going to get into how those are designed, the sanitariums and the cruelty of all that, but basically that's the idea. Patients who come in with COVID to any hospital are isolated to prevent them from transmitting COVID to other patients. That's the case with many infectious disease, in fact. So we do separate patients with COVID in the hospital, regardless of who they are, to prevent them from other patients from picking it up. The second thing to keep in mind is that if you're thinking of separating out COVID patients from everyone else because of, let's say, vaccination, as we mentioned, the majority of patients coming into the hospital with COVID are still the vaccinated. So from an equity point of view, you really haven't solved anything if you made, let's say, a COVID hospital, because it would be filled with mostly vaccinated people. Again, it's a small proportion of the overall vaccinated population, but they still make up the most of the hospitalized patients currently. Mm-hmm. So separating them out really wouldn't accomplish much in that regard.
From Marianne B., some people are already having their 4th vaccine. Are they getting any closer to providing an easier way to boost our immune system than repeatedly having to have vaccines? People are in vaccine overload.
So there really isn't another way to boost your immunity unless you actually pick up COVID, which no doubt provides some degree of boosting, but we wouldn't recommend to anyone to intentionally get COVID for that purpose. The fourth dose has very limited evidence compared to the third dose, which generally speaking has more evidence to support its indication to prevent severe disease. With the fourth dose, we're not as certain. Currently in Ontario, the fourth dose is provided to a select population of essentially very immune compromised and elderly individuals living in long-term care facilities, for example. That would really be the population, that severely immune compromised population is really who gets the fourth dose. But in terms of the vaccine overload, hopefully what we're moving to, if it's indicated in terms of fourth, fifth, sixth vaccine, would be a similar vaccine rollout, just like the flu. So getting an annual flu shot, hopefully, if we do need more COVID vaccines, we have something similar where there's some predictability about it. Between October and March, essentially, you can go get your flu vaccine, similar, hopefully, for COVID. And so you won't be in overload. You're not constantly thinking about having to book your vaccines or getting in line or any of that stuff. And maybe you'll even be in the same bottle. You get one shot, a flu vaccine and a COVID vaccine. Hopefully that's where we're headed if we need it.
From Danny, does UHN have antivirals that can effectively treat immunocompromised patients that are in ICU with Omicron variant?
So when you think about COVID treatment, really you can think about it in two kind of phases. In the early phase of the disease, the virus is common in your body, replicating at high levels, and antivirals work at that early phase. So to answer that question, there's Paxalvid, which will become available very soon. There's also another drug called remdesivir, which is an antiviral, which treats COVID in the early onset of the disease within the first around 5 to 10 days or so. The second phase of the disease is marked by inflammation. So the virus is now gone or at lower levels, but your body has a severe inflammatory response to the virus. And the way you help those people is by giving them a medication to try to reduce the swelling. And we also have drugs that do that. For example, what's called anti-IL-6 inhibitors. Those are a form of an anti-inflammatory medication that try to reduce that. And steroids, which has been the mainstay of treatment for COVID for more than a year now. So yes, there certainly are medications, more and more medications available to treat patients. Some of them are anti-inflammatories and some of them are antivirals.
From Srini, heard about a new COVID-19 variant called Deltacron identified 5 days back in Cyprus. Is it true also that it is as virulent as Delta and fast spreading as Omicron? How should we protect ourselves, especially from this variant?
I'm not familiar with this specific variant. And as with all variants, it usually takes time for us to understand what the variant is like, whether it's more transmissible, whether it causes more death or hospitalization. Usually takes a few weeks for us to understand that. With Omicron, it took us about 3 weeks from when it was detected to understand whether all those features, because you have to look at those numbers in the population. But as to the answer of how we can protect ourselves without knowing anything about this virus, I would say vaccination is still always going to be the best way to protect yourself. So far, there hasn't been a single variant that has caused caused vaccines to be completely nullified. So far, vaccines have remained highly effective against every single variant out there. So that will always be the most effective way to protect yourself.
From Charlene, my family got COVID mid-December. Should we wait 3 or 6 months to get a booster? Do we even need one, since our immunity from Omicron is probably stronger than a booster, which is designed to fight a slightly different version of the virus?
Yeah, that is a great question, is when do you get a vaccine if you just had COVID? The answer isn't as clear, but the general consensus has been to wait at least 4 weeks after you've had COVID to get a booster. And it is absolutely recommended that you do get a booster. And that data is actually just really, there's lots of data that shows this, but another nice study was just done about this, showing that those individuals who got boosted after getting COVID have an extremely high level of antibody response, higher than those individuals who were vaccinated and never actually had COVID. So you get a very, very good response if you get boosted after you've had COVID, a very, very high one. So absolutely. So whether you should get it at the 1 month mark, 2 month mark, 3, it's unclear, but wait at least a month before you get boosted. And that would definitely be a strong recommendation for you to do that.
I wanted to ask you, Alon, then there are a lot of people will say after they get COVID, they now have boosted natural immunity. Is that the case?
To some degree, they are immune. We know that if you've had COVID, your likelihood of picking it up again within 90 days is very low. The overall reinfection rate, it tends to be quite low. Of course, Omicron might change that. but certainly you have a high degree of immunity after you just had COVID. But that wanes, and it wanes to what, at various degrees in various people. Some people that will wane within 30 days, and some people will wane over 6 months. Whereas vaccines have a far more predictable waning, which is, we think, so far around 4 to 5 months if you've had 2 doses, and hence the need for the booster. So yes, even if you had COVID, you're likely going to be immune for some time, but we still recommend the booster after that.
Good point. Okay. From Sandy, how can the average person purchase the proper K95 masks? We are having trouble finding them, and I don't think Sandy's the only one.
Yeah, there is a challenge because of availability. Unfortunately, it's hard. I can't answer that. I don't use a K95, so I don't purchase them. But there are online websites. I would just say to be very careful and make sure there's good product reviews, because unfortunately there's a lot of counterfeits out there, and hence why you may not be sure what you're getting. So it's important for people to do their research on these K95s, look for ones that are perhaps made in Canada or in America that may be more reliable. It may be challenging to find those. You may only find them from overseas. So I'm not sure why I don't have a reliable resource to provide for some people.
I have colleagues who are picky on waiting for specific brand of Pfizer booster vaccine. What can I do to help resolve unfound bias?
Yeah, so there's very little difference between Pfizer and Moderna, the vaccine, when it comes to mRNA. There's effectively no difference. And in fact, Moderna, some studies may actually show Moderna has a better protection than Pfizer. But both of them are equivalent in terms of hospitalization and death. So there's what you could tell your friends or your colleagues is that the contents of the vaccine are nearly identical. There's differences in doses, but they are interchangeable. They are interchangeable for every healthcare worker, every person in the public. We don't make any distinction between the two. So you should absolutely just get whatever vaccine is available to you.
And you have that from Dr. Alon Vaisman. From Pat, Omicron is the 15th letter of the Greek alphabet. We heard a lot about Delta, with the 4th letter, I'm guessing. And then we started hearing about Omicron, number 15. Were there variants 5 to 14 that we did not hear about? And if so, why not?
Yeah, so there were some that were just really in South America that didn't really transmit to other parts of the world. And then sometimes the reason they skipped a few letters might be for political reasons, or it might be because it might not be easy to hear the word. Like it may be like too hard to understand the word for most people, or it has it's a homonym with something else that's commonly spoken. So that's why they chose Omicron. But yes, there are some that were just outright skipped, and some that actually were named, but simply did not become very common, because the WHO is trying to look very early on to find these things. So they might have been preemptive in naming them, but they ended up kind of not resulting in mass transmission to other continents. So you never heard about them because of that.
That's interesting. Just wondering if people who get and recover from COVID have the potential built into their bodies years later to have another sort of event outbreak, similar to the relationship between chickenpox and shingles?
Excellent question. So chickenpox, the virus that causes that, and shingles is a virus called Varicella zoster. It's part of a big group of viruses called the herpes viruses. This group of viruses has the potential to have latency, which means none of them are curable. So for example, the same disease that causes mono is with this group, or herpes simplex. None of them are curable. You get them and it becomes latent. In other words, it hides somewhere in your body. With the case of chickenpox, it hides in the special cells in your spinal cord, and you can never cure it, but it can pop up and go away throughout your lifetime, and you could try to give antivirals to try to make it go away. With COVID, it doesn't have latency in that way. Like all the respiratory viruses, it can't actually become latent and live inside the cells for any long period of time. Once your body has cleared it, it's gone. If you get COVID again, it's not due to a recurrence, it's due to a reinfection. In other words, you got exposed again, you got COVID, and now you have the virus again. And you might even get a different strain of the virus, of course. But no, it doesn't have that same capacity as chickenpox.
From JJ, ventilation and filtration are the two additional things that can help prevent transmission of aerosol-based viruses like COVID. Since ventilation is difficult in winter, please provide more detail and options on home filtration devices beyond just saying use a HEPA filter.
Yeah, so HEPA filters are certainly one option. The other easy options is to try to open the windows during the winter. But I would say also to think about in what settings you're improving ventilation. If you're just living with your family and you have ongoing contact and exposure to them, it's not as essential that you improve the ventilation because the likelihood of exposure with Omicron, if somebody picks it up, is very high. And so the measures that you might undertake to try to improve ventilation, it may not be very effective in that setting. However, in public settings, absolutely ventilation is very important. So in schools and hospitals and grocery stores, absolutely. In those kinds of settings, there are many things those areas will do to improve their HVAC system, like improving the air exchanges, using induction units, for example, using portable HEPA filters are also added, checking their filtration, replacing them. There's many things you could do in those settings, but in a home setting, there's very limited options to do that. So if you are interested in those questions, you could certainly ask, if your kid goes to school, you can ask them about the ventilation system and try to understand, look online about the details. But in general, what we look for is a very updated HVAC system that has high air exchanges in generally bigger spaces. Some people have used CO2 measurements as a surrogate for ventilation. However, it's important to understand the limitations of that and that it's never been clinically correlated with COVID transmission, but it can be used as a rudimentary measure in some settings to understand the ventilation.
Very helpful. Do you have more information on what causes long COVID and if it is a permanent condition?
So this is a very tricky area because the evidence has been fluctuating about what is long COVID and how long does it last. There's seemingly no doubt that some patients have had COVID, even the ones acquired COVID in the very beginning of the pandemic, have some kind of residual symptoms now. So we really don't know how long it lasts because the pandemic has only been around for 2 years, but presumably people have had, a very small number of people probably have had long COVID since that time. In general, the likelihood of developing is quite low. And as we said, vaccination essentially gets rid of that risk altogether. And so what causes it? It's, there's a lot of ongoing evidence or studies looking at what causes it. There is some degree of inflammation that's associated with COVID that damages certainly the vessels of the body that causes these symptoms. As for the neurological symptoms, it's not quite clear why it happens or what the mechanism is or what the treatment is, but there's lots of ongoing research looking into that.
Well, I'll put a shameless plug in for UHN Research and the podcast I host on uhn.ca. If you go to look for podcasts, Behind the Breakthrough, one of the leading researchers in this country, Dr. Angela Chung, is the most recent interview on the podcast. From Erica, do the pneumonia vaccines help protect from COVID effects?
Not exactly. So if you by pneumonia vaccines, you mean pneumococcus, which is a bacteria. That vaccine doesn't have any protective effect against COVID as far as we know. But certainly if you have pneumococcal pneumonia and you happen to acquire COVID, that's certainly a bad thing and you'll have a worse outcome. So for example, in elderly people who get this pneumococcal pneumonia, which is a very, very common bacterial cause of pneumonia, that would be protected. You'd be protected if you can get the vaccine in the sense that you won't have two infections simultaneously, or you won't have damage from one infection that would leave you susceptible to another infection. So there isn't a direct protective effect, but absolutely there are certain groups who should get pneumococcal vaccination, like the elderly, people with chronic lung disease, people who smoke, people who live in congregate care settings. Those are the patients who should get pneumococcal vaccination.
Well, we've come to the end of our time today. We're approaching top of the hour and we have to get Dr. Vaisman back to work. So to all of you out there, thank you for joining us. To our special guest, Dr. Alon Vaisman, UHN infection control physician. Thanks so much for taking time out of your busy day to share your insights and expertise.
Thank you. Thank you for having me.
This live stream will, of course, be available on the UHN Foundation YouTube page shortly. And finally, donor support. If your dollars do fuel the groundbreaking research initiatives of our award-winning UHN scientists, and they are working to improve and discover new treatments for patients suffering from COVID-19. So if you're able to give, we ask you to consider making a donation by going to www.uhnfoundation, that's all one word, uhnfoundation.ca/help. Thanks for tuning in, everyone. We'll be back with another episode next month. Keep an eye on your inbox, your email inbox for details. In the meantime, be kind, mask up, and please get vaccinated. Stay safe, everyone.